Thanks, Sandy, for the introduction. So, as Sandy says, my name's Sandy Picken, and I'm a guideline developer at the Knowledge Translation Unit based at the UCT Lung Institute. So the Knowledge Translation Unit, or the KTU as it's commonly referred to, is a health systems research unit that's spent the last 16 years developing health systems programs and conducting implementation research evaluating their effect. This slide gives you a brief overview of what we do and what we've done in the past. At the core of our health system programs are clinical practice guidelines that are supported by robust implementation strategies. Our programs have been adopted nationally with over 20,000 health workers trained in about 2,000 public sector clinics. We have a research team which have conducted 4 large pragmatic randomized controlled trials which have shown modest but consistent improvements in a range of outcomes. In 2014, our unit partnered with the BMJ, and we took our adult version of the guideline, we evidenced it and adapted it to a lower middle income country setting to create a generic form of this PAC called PAC Global, which aligns with WHO guidelines and the essential medicines list. We've subsequently mentored teams in country to adapt and localize this generic version to create PAC Brazil in Portuguese and PAC Nigeria. And these programs are currently being implemented at the moment. To give you a little bit of history of how PAC has evolved, PAC evolved from a WHO strategy called the Practical Approach to Lung Health. Over the years, there's been many iterations responding to end user need and disease profile. PAL was localized to South Africa to become PALSA. HIV content was then added in with the advent of the ART program to become PALSA Plus. Stretch then introduced the task sharing component, supporting nurses to prescribe ART. PC 101 saw the development of a comprehensive approach to the adult, and this was adopted nationally. And then PAC, which stands for the Practical Approach to Care Kit, is similar to PC 101, but the Western Cape PAC has been obviously updated and tailored for a Western Cape setting. PAC CCW, Community Care Worker, and PAC Information, which are the patient information leaflets, were developed shortly thereafter. And part of our team has spent the last 2 years with funding from the Children's Hospital Trust developing PAC Child. To note, we update our guidelines annually to keep pace with evolving evidence and policies. We also use an evidence-based implementation strategy called educational outreach, and this is currently being rolled out within the system using a cascade model to deliver on-site training in facilities. So essentially PAC is responding to primary healthcare clinician needs. There's simply too many patients with too many problems, and there are obviously too many textbooks, guidelines, protocols, circulars, and policies to comply with. Our answer is PAC. So importantly, PAC is not a textbook, but it aims to be that simple tool that a clinician reaches for during a primary care consultation. Hence, its essential features are that it's comprehensive, it's simple to use, it helps the clinician integrate routine care into every visit, it helps them deal with the patient with more than one problem, and it's practical and locally feasible. Of note, PAC is not aiming to replace IMCI. It aims to reinforce and build on its successes and address some of its limitations. For instance, PAC Child deals with the well child, the child over 5 years old, and the child with a long-term health condition. So PAC Child's development has been a consultative one, and it's involved many, many iterations of each page in the guideline. It starts out with drawing up a draft, which is basically or largely based on local practice and policy and evidence. And it's then sent out for expert review. And many of our sections, like respiratory, nutrition, mental health, neurodevelopment, TB, HIV, all required numerous multidisciplinary clinical working groups to actually finalize pages. To date, there's been about over 170 clinicians which have contributed to PACCHILD's content. We've also worked closely with the Western Cape government and collaborated with multiple clinical governance groups to ensure that PAC content reflects provincial policy and health system realities. So just to profile a bit of how PAC works, PACCHILD has an initial component which integrates the routine care of the child at every visit. This prompts the clinician to not only deal with a presenting complaint, but to think about the child holistically, looking at not just the standard immunizations, deworming, development, but to think more broadly about TB and HIV risk, health of the carer, school problems, mental health problems, along with many others. Following this, we have a first half of the guideline which covers common or provides a symptom-based approach to many common childhood illnesses and starts with an emergency section. The second half of PACCHILD provides the clinician with a guide to diagnosing and managing children with long-term health conditions such as nutrition, TB, HIV, allergy, which includes eczema and asthma, a section called Other Long-Term Health Conditions, which incorporates known heart problems, bronchiectasis, and chronic arthritis, epilepsy, special needs, and a palliative care page. The main thing that distinguishes PAC from other textbooks and guidelines is the information is arranged in the way that a patient presents to a clinic. This makes it easier to access the information when a patient presents with a symptom. So our symptom-based approach, we have one symptom arranged per page. Check in the red box to see if a child needs urgent attention and referral to the next level of care. If not, then follow a simple algorithm. Similarly, in our long-term health conditions section, we have a standardized format. What to assess and when. Notice there's 3 tones of gray indicating history, examination, and investigation. What to advise the carer, and what medications to prescribe. PAC also uses every opportunity it can to prompt the clinician to consider long-term health conditions. And to showcase a few examples, this tired or lethargic child page prompts the clinician to think about 6 long-term health conditions. Similarly, the recurrent respiratory symptom page might prompt the clinician to think about a diagnosis of asthma, or a child with allergic rhinitis on the no symptom page might prompt the clinician to think about other allergies. Again, similarly in our long-term health condition section, we prompt the clinician to think about common comorbidities at every opportunity. So PACCHILD also has the potential to facilitate task sharing and shifting and expand prescribing provisions. Doctor and nurse roles and responsibilities are clearly defined using color coding of medications. Each color indicates who may prescribe what and at what dose and for which indication. We've also closely discussed with primary, secondary, and tertiary facilities to try and make PACCHILD clear about when it's appropriate to refer a child, and where to refer a child, and how quickly to refer a child. So in conclusion, PACCHILD helps the clinician to screen for long-term health conditions. It guides the clinician through diagnosis and routine care of long-term health conditions. It prompts the clinician to look for comorbidities. It supports task shifting and sharing, clarifies referral pathways, and it supports a team approach to long-term health conditions. Thank you very much. Wonderful care code.
Thank you. I've had the opportunity to look at this, and I think it's very impressive, and you've done an incredible amount of work. But the good thing is that it's very useful. So my question really then is about what's your dissemination strategy? You're clearly introducing it in the Western Cape. What's your plan to take it beyond this province? How do you intend the rest of us to use it? What's your dissemination strategy?
At the moment, we're still in the initial stages. We've just finished the development of the guideline. And the plan is a slow, phased-in pilot implementation during 2017. So it goes along with the health systems evaluation. It's going to be phased in and piloted in one clinic only, and then iterated, then 3 clinics, and then 3 to 6 clinics following that. And based on that, the planned rollout is for 2018.
If I'm allowed to ask a question. So is your pilot going to be in the Western Cape, or are you looking at piloting elsewhere? So at the moment it's all Western Cape.
This is a Western Cape project at the moment. It's funded by the Children's Hospital Trust.
Sandy, thanks very much. I understand why I keep thinking I've got to see what you guys are up to. I'm really keen to understand how you see its interaction with IMCI. I'm concerned and interested, so it would be great to hear.
So yes, there's a few details that need to be ironed out, but as I said, we are not trying to replace IMCI, and IMCI is often part of the competency-based training, and it holds the clinician's hand through learning how to examine and deal with a child. Our focus, especially with the initial training, will be focused on the areas that IMCI doesn't cover. So particularly the well child and routine care, the child over 5 and long-term health conditions. And yeah, the pilot it's going to be a focus of the process evaluation during our pilot for 2017. And we're going to go from there. I don't know if you want to add anything, Ruth?
Well, I work with Sandy, and just to say that, I mean, we've all the IMCI,
Double way. As a nurse clinician, and as a practice improvement, practice development clinician, is that as soon as you've got 2 documents, people use neither. So we're going to put 2, and then maybe they're adjusted or they're adapted. It's a little bit what we have done with ETAT or not, or it's so confusing in practice. So I'm grateful you're doing process evaluation. Please keep that as a core thing. It's a terrifying point, but thank you.